now invite Dr. Ruma Sathwik, Senior Consultant, but not only for today, for from tomorrow she takes over as Vice Chairperson at the Center of IVF and Human Reproduction at Sir Banjara Hospital, New Delhi.
Ma'am, I have only one question. Is endoscopy needed in all patients? Is a question which has always puzzled us in our day-to-day practice.
So, it's really the reason why we are having this talk is because clearly there is a case to be made for not doing the procedure, either hysteroscopy or laparoscopy in women who undergo IVF. The question is, we are all trying to optimize results for our patients. We want to make sure that there is no anomaly that has been overlooked and that anything that has been found has been addressed either through medicines or through surgery. And for the longest time, somebody had to guide me on how to use this. It was being done as a routine procedure, hysteroscopy, pre-IVF. And the reason was that people said even though ultrasounds revealed no evidence of an anomaly, you would still find an unsuspected problem in the uterus that needs to be addressed, maybe in up to 11% cases. Until there was this particular review, Cochrane review, that came in 2018, which clubbed evidence from 2 randomized controlled trials, which suggested that a screening hysteroscopy is not always needed if your ultrasound was clear. However, the same review said if you have had multiple failures, it helps to do a hysteroscopy because you may find evidence of some disease. This evidence comes from 3 randomized controlled trials, of which the one with the least bias that shows all 7 squares in green, which means that it has a very low risk of bias coming in from the researchers or other reasons, is actually saying even with failed IVFs, hysteroscopy may not be needed. However, as evidence stands now, it suggests perhaps in failed IVFs, multiple failed IVFs, a hysteroscopy could be done. What happens when you actually find a uterine anomaly on an ultrasound, which could be a fibroid, a polyp, adhesions, or septum? Let's get the one which occurs very commonly out of the way first. So we're looking at submucous fibroids, where we understand that the location of the fibroid on where it exists in the uterus, close to the cavity, will decide whether it affects implantation or not. So there are 3 kinds: submucosal, intramural, and subserosal. We all know this, we follow this, right? And there is evidence from non-randomized controlled trials. And in this systematic review, which pools evidence from several studies, what it suggests is that clinical pregnancy rates drop to about a third of what it can actually be without error, or type 2 error, which is that an actual potential for harm exists because of submucous fibroid, but it cannot be picked up because the numbers are too small. However, so what we are looking at is what ASRO recommends, which is the American Society for Reproductive Medicine. So the recommendation based on non-randomized controlled trials, and of course intuitively we know that removing it is likely to help, is to undertake a myomectomy, a hysteroscopic myomectomy, to remove these submucosal fibroids. So we are clear about this. The World Societies also say that if the fibroid is submucosal, do your hysteroscopy, remove the fibroid. If it is outside the uterus, which is called subserosal, or a substantial bulk of it is outside, you do not do a laparoscopy or a hysteroscopy, let that be. But if it is intramural within the muscle of the fibroid, you may need to, World Societies tend to differ. It seems like if it is intramural, the location, how close it is to the endometrium, and the size would matter. As you move away from the endometrium, the size at which implantation starts getting affected keeps changing. So something as small as 2 centimeters, very close to the endometrium, is likely to affect implantation. But we all come from centers where IVF itself costs so much. Do you really want to intervene for the type 3 2 centimeter fibroid through a laparoscopy, which could be of equal cost as an IVF? So here is the middle solution proposed by this author, Dornans, who has a substantial body of work over the 2 decades that he has written literature. It suggests that and this is like a pretty comprehensive chart on what to do if you find fibroids in women who are infertile. For type 0, submucosal fibroids, we've already seen a myomectomy is recommended. But for type 3, 4, 5, intramural fibroids that are larger than 3 centimeters, you could still go ahead and you know that this woman needs an IVF for various other reasons. It could be a male factor, tubal factor, whatever. You needn't yet scope, you needn't yet do a laparoscopic myomectomy. Go ahead, do your pickup, make the embryos, freeze them, use agonists or antagonists to shrink those fibroids. In all likelihood, you'll have a response. It might shrink to a level which has reached a point which no longer affects implantation. Only if it doesn't reach the size that you need it to would you want to do a surgery to remove this fibroid. Right? What about polyps? Again, a very common entity found in more than 10% patients. Sometimes you get it while you're stimulating the woman. These are overgrowths of the endometrium into the cavity. It's a benign kind of overgrowth. And these are results from a trial done on women undergoing IUI, which is also a kind of fertility treatment, where removal of polyp had these dramatic effects on pregnancy rates, right? So 64% of women who had their polypectomies conceived, and only about 28% of women who did not have their polypectomies conceived. And that's a dramatic effect. Based on this single randomized trial, we have recommendations, but also through other non-randomized studies of intervention, which I'll be coming to. What we need to look at in this study, the polyp sizes varied from 5 millimeters to 20 millimeters. So we have always had this impression in our heads that these polyps are 10 millimeters and more. You needn't really address them, but this trial had about 50% of women where polyps were less than 10 mm, and you could see the beneficial effect of polypectomy. This is another trial looking at size, whether size matters or not. And you can see that where polyps were less than 1 centimeter versus where polyps were more than 1 centimeter, both having been addressed by a hysteroscopic polypectomy, a surgery. The results in both the cases are similar, suggesting maybe a cause-effect relationship of even smaller sized polyps on results. Right? Location, I wouldn't want to address this if you are undertaking IVF, but in women who want to conceive naturally, polyps are the only cause. Polyps at uterotubal junction might improve natural fertility. So this is the recommendation. This is from Cochrane Database 2018 that says that the clinical pregnancies improve after polypectomy. The odds improved by 4 times, so it's best to undertake this. Now, this is an entity which exists in about 1 to 2% of women undergoing IVF, and it is always a question on whether to resect a uterine septum or not, or you just let it be. What is a uterine septum? It's a division of the uterus by a fibrous wall into 2 parts, because it was a developmental sort of tissue that should have resolved, but it hasn't, and it still exists. So it has been linked to recurrent pregnancy losses, obstetric complications, malpresentations during labor, and a higher incidence of preterm labor. So this is a trial which took 20 years to complete, and again what we see here are results of septal resection versus no septal resection. And you can see that there are 2 sort of lines that go up they are mostly following each other. And what the authors concluded was that septal resection isn't really working for women who are infertile or for women who are seeking babies. So these are the study details. In this trial, there were only about 40 women on both sides. And these included women who were not just fertile, but who had had preterm labors, who had had pregnancy losses, and these were the other complications that one saw. The complications with septal resection was uterine perforation, 1 out of 39. The other complication concern was incomplete resection requiring a repeat surgery. So these are things that one needs to talk about for what. All this was undertaken for a live birth rate which looked similar in both arms, 31 and 35%. And interestingly, you see that pregnancy losses are higher in women who have undergone a septal resection than those that haven't, although it doesn't reach statistical significance. So where are we today? These are, and again, this comes from Cochrane database 2025, and there's something unusual here. You know that Cochrane only talks of results that have been generated from randomized controlled trials. And for the first time, in fact, I saw this, where it has considered non-randomized studies of intervention as well. And there is a good reason for that. That if you think a surgery is going to help a woman, it is very difficult to generate a trial where you will have women saying yes or no to the surgery, and everyone seems to perceive the benefit of a surgery. And so to do RCT on every possible subject is not always possible. So Cochrane acknowledges that, and in 2025, it clubs studies that are not randomized as well to produce this result, which is saying it does not help uterine septal resection in either increasing live births or in reducing miscarriage rates. Alright, so that is the conclusion. So the question, and this is what ASRM then suggests, what does it suggest? Even though it is linked to miscarriages and obstetric complications, there's an automatic association. Resecting before initiating infertility treatments, that is IVF, even though it's reasonable, is not supported by evidence. So clearly, would you do that? I wouldn't, I would probably let it be. But if there is a history of acute miscarriage, perhaps I would undertake septal resection. And if I were doing it, I'd use the scissors more. The loop or the needle electrode, yes, but the top of the septum probably needs it. Cutting cervical septum leads to incompetence. This was a very widely held belief. The answer is no. Residual septal resection, I would not do if it is less than 1 centimeters. And uterine perforation or hemorrhage is something that you have to be wary of. Counsel the patient that there might be complications, even though rare. What about this? Now, this is something that we come across often. They are called synechia, which is adhesion bands inside the uterus. And in the ultrasound, the HSG or an SIS are different ways to diagnose it. And clearly, there is a case to be made for addressing this. Nothing looks normal here, right? We are looking at evidence because that's what the talk is about. And it's like I said, it's difficult to find RCTs, randomized controlled trials in this subject. I've done my bit, and I have to admit, I limit my search to PubMed. I don't know if other RCTs exist or not. So the only comparative trials that exist on the subject where you undertake intervention or not take intervention are non-randomized trials. So we just have to make do with these cohort studies. Now, this one cohort study is looking at mild adhesions as per AFS 1988 classification, and saying that please do not undertake intrasyneculisis because it is not going to improve life births or reduce your miscarriage. So what are mild adhesions? We of AFS, which describes mild lesions as having a score of less than 4 based on the above criteria, extent of cavity involved, time of lesions, pattern, and all that. So for something like that, you do not undertake sinecurisis. Now, the other cohort study on sinecurisis is a comparison between when you remove it versus a control group when you remove polyps. So, sinecure removal versus polyp removal, do you approach the same level of pregnancies and live birth rates? As per this cohort study, yes, you do. And however, the baseline characteristics are unclear. We are not sure what kind of sinecure they are talking about. But the same study suggests that a woman with sinecure, or a woman with adhesion bands inside her uterus, is likely to have more obstetric complications as seen by the results here. What are these complications? Radiant placenta, placenta-radiata syndrome. And so please, as specialists, as gynecologists, if you know that this woman has had intrauterine sinecure, is pregnant currently, be wary of these complications in this woman. So go ahead, do the lysis using needle electrode or scissors, and understand that there is a recurrence rate of about 20%. So there are some adhesion prevention measures which the AAGL, Society for Gynae Laparoscopists, recommend. And that's the final bit which they say, do your adhesiolysis, use a barrier method, and they say there's no difference between what barrier method you use, a balloon versus your inert lipase loop versus a barrier like an intra-adhesion prevention barrier. You could use any of those and the results would still be the same. And of course, do an estrogen therapy and a second look hysteroscopy. This is a common issue that we encounter in endometrium before we do an endometrium transfer. And this is the data from a large retrospective cohort, which says that as the endometrial thickness goes down, the live birth rates come down, the losses go up. And so, what is the recommendation with respect to thin endometrium? See, we all do maybe 70% of our transfers happen in a frozen embryo transfer cycle. If in a frozen embryo transfer cycle you encounter thin endometrium, you'd want to ensure that your preparation method was right. Have you used estrogen oral tablets? If you have, it's not always likely that it will produce the same blood levels of estrogen in your blood. So perhaps you need to switch from the oral route to the transdermal route or to some other route in order to produce the right blood levels, which can then change the endometrial thickness. So you base this on morphology. Morphology is looking at normal hysteroscopy. If there have been previous transfer failures with thin endometrium, hysteroscopy. Etiology, no Asherman's uncorrected, you can still transfer after counseling. If this is no Asherman's that hasn't been addressed, you do a hysteroscopy. If you think a relook hysteroscopy is going to work, perhaps go ahead and undertake it. This brings us to the next topic, and I promise I'll just keep it to under 5 minutes. Laparoscopy prior to IVF. So that was about hysteroscopy. We're talking about should we do a laparoscopy prior to IVF. It has been done for various indications. The common ones are hyperthermia, endometriosis, and fibroids. We all sort of have done this to bits, whether you remove an endometriomite or not prior to IVF. And the answer is you don't do a laparoscopy to improve on AFS, that is on grade 1, 2 endometriosis. You don't do a laparoscopy for endometrioma, and you don't do a laparoscopy to remove deep infiltrative endometriotic spots. However, you may have to undertake a laparoscopy if there is intractable pain associated with deep infiltrative disease. And sometimes you may need to undertake laparoscopy to improve accessibility to follicles. Right? Those are the two reasons. Large endometrioma, perhaps the follicles that are distal to the endometrioma are not always accessible, so in those cases, we would want to undertake a laparoscopy. What about hydrosalpinx? Evidence hasn't changed in the last 15 years. It remains the same. First is that hydrosalpinx per se, which is fluid in the tube, reduces the odds for clinical pregnancy, and that reduces to half. The mechanisms that have been proposed are flushing, toxic fluid, or altered endometrial receptivity, and ASR has done its own bit of pooling the results from different studies where occlusion was undertaken versus no occlusion, and it's seen that the relative risks, or actually the chance of having pregnancy after occlusion, is about 2 times higher versus if occlusion was undertaken with hydrosalpinx. So go ahead and do a laparoscopy to clip hydrosalpinx. However, there's a caveat. You may not always be able to do this based on how dense the adhesions are, how many surgeries have happened. So there is this term that is used, frozen pelvis. If that has already been proven in the past, she's had an intestinal injury in the past, would you want to undertake something like this? There are other measures also, perhaps less effective. These are sclerotherapy, and there is salpingeal fluid aspiration. Sclerotherapy is undertaken by the conventional radiologists, and for now, whatever evidence we have, its results are similar to tubal occlusion. Hydrosalpingeal fluid aspiration, perhaps if you were undertaking an egg retrieval, you could do it at the time of retrieval and transfer, let's say, 3 days later. The likelihood of fluid forming again in 3 days is low. However, if the delay in transfer and aspiration is longer, the chance of fluid collecting in the tubes, the blood tubes, is very high. So this is to be undertaken only when a surgery is not possible for hydrosalpinx. So conclusions, do you spook, do you do a hysteroscopy prior to IVF? Yes, for suspected endometrial polyp. Yes, for submucous fibroid. Yes, for dense or moderate intrauterine adhesions. Yes, for repeated implantation failure. Yes, for recurrent pregnancy loss with septic uterus. And yes, for thin endometrium with abnormal morphology. When do you not do it? First IVF cycle with normal imaging, non-cavity distorting fibroids without indication, mild adhesions, mild intrauterine adhesions, IVF failures as a result of poor embryos. And that is something that is another topic, we can talk about it. But there have been 2 IVF failures, and it has been established that it was because of the embryos, because you knew what the grade of morphology of the embryos were, you would not undertake it. What about laparoscopy? Not endometrioma, blocking access to follicles, do it. Hydrosalpinx, yes. Not symptomatic uterine fibroids, yes. Undiagnosed pelvic mass, yes, I've added that indication. But do not scope for endometrioma with decent follicular access or small multiple fibroids. I think I'll end there. It was a long talk. I enjoyed being here. Thank you, Sandeep, and thank you, organizers. All the best.
Now, I have one question. With respect to FIGO for the most controversial ones, how do you handle them with respect to the size and indications of medical management in time 4, and when is it that time that you shift from a medical management to a surgical management?
So is it fibroid you're talking about?
Yes, fibroid.
Okay. FIGO stage 4 you're talking about, which is intramural. And size would matter. I think being symptomatic matters. So heavy bleeding during periods, I would want to remove it. Usually a fibroid of 5 centimeters or more would do that. It ceases to be purely an intramural fecal food, becomes a hybrid thing. So if she's not symptomatic and the size is less than 3.5, 4 centimeters, I would probably do the IVF. I would do medical management with injectable agonist depot for 3 months or 4 months in order to bring the shrinkage to less than 3 centimeters. And then if there are many embryos that she has made, it's all right to maybe try the medical management first and do a transfer in a segregated cycle after some shrinkage has been demonstrated. But if there is just that one embryo that she's made, this is an elderly woman, and you want to give her the best chance, I would perhaps remove a 4 centimeter intrauterine fibroid and then undertake a transfer to mother.